Hi everyone, we'll make a start. My name is Dua Abdalal. I'm a program support manager and I work for the NHS England Cancer Programme. And yeah, thank you so much for joining us for session 4 of the MDT Improvement Programme. And today we're going to be focusing on MDT preparation. And on the call, I've got a few of my colleagues with me. So I've got Robin Cutforth, Alison Paul, Matt Noonan, and Crystal Skinner. So for today's session, we're going to be focusing on a few different case studies. And the first will be on patient-focused information. That will be with Keely Agnew, who is a Macmillan colorectal specialist nurse. And then afterwards, we've got Elizabeth Bright joining us to talk on our case study as well. And then Kaylee will be back again to do a post-MDT patient communication. And at the end, we'll do another one of our favorite chat bombs and do a little action learning set. So, as usual, our expectations are if you can, please do put on your cameras. It's just nice to be able to see each other and to be able to have a more like engaging interaction with each other. Please do keep yourselves muted when you're not speaking and whilst people are presenting. Please do feel free to actively participate. You can use the chat box whenever you'd like to, so feel free to put any messages in there, any questions, and then use the raising your hands function to be able to ask questions. Please do try and actively listen and give everyone your full attention. And like I said, please do use the chat box so you can ask questions, share any insights, anything like that. And stay open-minded, be receptive to the fact that everyone's different perspectives and approaches from other participants as well. So yeah, like I said, please do use the chat box because it is always nice to see what everyone's thoughts are. So we're going to go straight into it. And we have Keely Agnew joining us, who is a Macmillan colorectal nurse specialist from the Northern Care Alliance NHS Foundation Trust. And Keely is going to be talking about patient-focused information.
Hi everyone, just bear with me. I'm just going to share my screen. If someone could just give me a quick thumbs up when you can see some slides, that would be amazing.
Will do.
Thank you.
Yeah, we can see them. Thank you.
Fab. Okay, so nice to meet you all. I hope you're all enjoying your course so far. So I'm coming to talk to you today about patient-focused information, as you know, and how we went about introducing that to our colorectal cancer MDT. So just to give you a bit of background, we were actually part of an NHS improvement programme with our Greater Manchester Cancer Alliance back in 2023. So the Cancer Alliance, made up of all of our tumour boards, put together a set of standards to introduce to the MDT. And we worked with them for 6 months to see how we could personalise that and tailor that to fit into our MDT ways of working, what would be appropriate and what wouldn't. And since then, we've carried on introducing various improvement standards as we've gone on. So the standards were basically keeping the patient at the heart of everything we do. So it included making sure we had the right input data into our MDT, making sure we were getting the right outcomes out of it. Our national data was up to date. We were doing all of our audits. And one of the big things for us is patient-focused information. And we did that by using a tool called a patient impact statement. And as a CNS, patient-focused information is something that I'm really passionate about. So we think patient-focused information is key to shared decision making. So the phrase coined by Andrew Lansley was "no decision about me without me." And when we reflected on our MDT working, we thought actually our patients do get to MDT without having any input into that decision, and it is very much a clinical focus. So we went back to basics and looked at our pathway and how we could make a difference. So some of the values that have been documented throughout research for patient-focused information and why it's so important is some people report there may be less need for repeat discussions, specifically if there's information about social issues, psychological or supported care needs, as that can influence patients' uptake of treatment options. As well as that, a large study by Cancer Research UK showed that 10 to 15% of MDT recommendations weren't accepted by patients. It wasn't their wishes. So if we had a bit of information about them before the MDT, then that could add value to our discussions. Also, some research has shown it could show better adherence to treatment, more appropriate service use, and less delays in treatment. And actually, as a whole, we think it's what our professionals and our patients want. Despite it being what our patients want, only 25% of patients feel that they have the opportunity to contribute to their MDT discussion. So what are the challenges to bringing about patient-focused information? Well, the key one for everybody working in healthcare is time. There's never enough time in the day to gather the information, to present it appropriately. And we know that year on year, our numbers of patients coming to the MDT are increasing, but the resource doesn't follow with that. And sometimes there are differing views as to whether patient-focused information actually adds value to the MDT, particularly because our MDTs were set up to make sure we met clinical guidelines. And then another big thing is, how do we do it? How do we gather that information, and how do we get the right information to the right place? So we went back to look at our pathway. So as colorectal nurses, we meet our patients in the endoscopy unit when they've been found to have a suspected bowel cancer. We sit down and have a very supportive conversation with them, and we talk them through their patient pathway. So we let them know what to expect in terms of staging investigations, timings, when they're going to be discussed on MDT, and actually what the MDT is. And we also have some really useful patient resources to explain to patients what an MDT is and how that takes place for the patients. And at that point, we thought that would be a key place to ask patients to have their input into the MDT and provide some information for us. We then move that information on to presenting it at the MDT, and we try and do that in the most succinct manner to make sure that it doesn't take too much time on the MDT, but also as it adds value to that discussion. And then we go back to our shared decision making and meet our patients to discuss what they would like to do to move forward with their treatment plans. So this is a patient impact statement. So this was created by the Greater Manchester Cancer Alliance, and in particular by their Gynae Pathway Board. They created a patient focus group, and the patient experts had input into what they would want to be asked for their MDT discussion. And they actually wanted to call it Please Listen to Me, because they placed so much emphasis of being seen and heard for their MDT discussion. They really wanted their point of view listened to. And essentially, the document centres around these three questions. Please tell us about yourself, what's important to you, who are the people important to you, what are you worried about right now, and what do we need to take into consideration when planning your care. So sometimes when we speak to patients, there's really simple answers. Well, you know, my family is really important. I'm worried about what my diagnosis will show if the spread of the cancer. And I don't want any considerations. I just want the soonest treatment plan. So then, you know, that's quite a quick thing, and it doesn't always add value to the MDT discussion. But then we also have patients who are carers and they can't come to appointment on a Thursday because the wife's having chemotherapy. Or we often see in colorectal land patients who are completely adamant they don't want to have a stoma, or it might impact their independence, or really strong views on things that we would want to know at MDT, because it might mould our discussion to make sure that the treatment plan is suitable to what they would want to take forward in the future. So earlier this year, we did a compliance audit to see how well we were doing in gathering this information. Unfortunately, it wasn't as positive as we wanted. So we only had a 50% compliance rate with completing the patient impact statement, but this has allowed us to see where we weren't completing it. And actually, we know it's because we've only offered it to that small group of patients referred by the endoscopy route, because that seems a key point in the pathway to introduce it. But now we know we can offer it out to our surveillance patients. So patients who have something on a surveillance scan, who ordinarily may just get added to an MDT, we now call them and explain that process and ask them if they would like any input into the MDT. So that's really good. We also looked at our repeat discussion rate to see if patient-focused information had an impact on that, and actually it didn't. None of our patients were rediscussed for that reason, and we have looked at the themes separately to try and improve that. So some of the barriers to introducing patient-focused information, well, one of them is having the key documents. So we're really lucky that we've got the patient impact statement and that was introduced to us. But actually, some research suggests potentially using documents like a holistic needs assessment, which is a really bulky, time-consuming document that requires a care plan off the back of it and doesn't ask specific questions about the MDT. Another barrier is patients don't know they're being discussed on an MDT. So when you're introducing patient-focused information, I'd say it's really key to know what's right for your patient along their pathway and when would be the right time to have them conversations. Also, the role of the CNS is ill-defined within the MDT. So I feel really passionately about being a patient advocate in the MDT, but actually a lot of nurses report anxieties about feeling valued or listened to. And some research suggests that nurses just don't talk in the MDT. So a large study by Cancer Research UK suggested that nurses didn't speak at all in 75% of MDT discussions, which is huge if you think about it. And I think if you really want to introduce patient-focused information to your MDT, you need to empower the people who are going to have that voice for their patients. And most commonly, that is the nurses who develop those relationships and ask those questions about that type of information. So yeah, all in all, I would suggest that you can introduce patient-focused information to the MDT. We can do it in a timely and succinct manner. You just need the right document and the right people to do it in your pathway at the right time. And if you do it, it can help improve the quality of your discussions, potentially impact your rediscussion rate, the acceptance of MDT recommendations, and potentially compliance with treatment as well. But more importantly than any of that, I feel like it allows our patients to be seen and heard, and they really take a lot of value from having their information discussed at the MDT and feeling like they're an individual going into that MDT. So that's my information so far. So I'd love to take your questions. So I'm going to stop sharing now so we can go back to the group and you can all ask me anything you'd like to.
Oh, that's great. Thank you so much. That's also like such an interesting way of doing things. I didn't realize that people did that interest. So like that's really great to see. And like having that audit is so, so important as well to make sure you're actually what you're doing is actually coming across. So yeah, really, really brilliant. And like I love the fact that you've taken the fact that the patients wanted you to put on that, please listen to me aspect of it because it is so important. So that's really wonderful to see. Um, Questions. Robin, you've got your hand up.
Yeah, thank you so much, Keely. That was so interesting. It's actually really, not surprising, but really disappointing to see how nurses contribute to MDTs and how they feel undervalued and unappreciated, which is really sad. Do you have any ideas about actually, how an MDT can encourage CNS participation more and make their nurses feel valued and a member of the team?
Yeah, and I think it's all about having good leadership in your MDT and coming to forums like this and just being open-minded and allowing everybody in the MDT to have a voice, not just your nurses, but there's people there with key information and they don't always feel empowered to talk up, or there isn't time for their voice to be heard. And I think everyone has something to add. So I think leadership and going through the MDT, having a good chair who sees who wants to talk and, allows that free-flowing conversation to happen.
Great, thank you.
Thank you. Malini?
Hi, it's very nice, Kelly, interesting. And I am surprised to see that, to hear that in some of the MDTs, the nurses don't feel like they have a voice. Because in our MDT, they are very important and they are the ones who are able to really fill in on what conversations they have had with the patients and their families and what their wishes may be. And they have a voice not only during our local MDT, but also in the regional MDT, but they seem to know the patients and their families in a way better than we do as clinicians.
Yeah.
Or as medical professionals. Everyone is a clinician, but as medical professionals, and we value their input a lot. And we may not have a very formal form the way you described, but I do know that the patients or the relatives' conversations or their wishes are recorded in the MDT performer and influence the final decision making or the way we even discuss it at the regional level at times. Because at the end of the day, we're all here for the patient and their wishes are very important. We don't have a formal way of doing it. And the letter that we do to the patients afterwards always say that it was discussed at the MDT and welcome their opinions and views. We don't do, I don't know how many of the other MDT people who are here in the meeting do have a formal form to document that. But yeah, thank you.
Yeah, I think a lot of people, and certainly we do, we feel that often the shared decision making takes place after the MDT. And it is quite often the case, well, the MDT is there to create a menu of treatment options, and then we'll take that to the patient afterwards. And that's often the kind of historic way of doing things. The MDT will say X, Y, and Z treatment options, and then the patient will then make an informed decision once they've heard that. Obviously, collecting patient-focused information can't take away from that, and the patient needs to hear all of those treatment options because they need to make an informed choice. So completing a form beforehand doesn't take that away. It's just more personalising things, and we often plan our patients' treatments and appointments straight after the MDT, which we can't always do without that personalised information about them.
Thank you. Does anyone else have any questions? Sarah's just put a comment in the chat saying they have a fabulous CNS team presenting at MDT, and they do contribute a lot regarding the patient and their status of feelings and testing. And they do also update the patients following whether it's about imaging required or booking results clinic. It's really interesting to hear people's different perspectives and like how different teams do work together and like the role of the CNSs and nursing teams in the MDT. So thank you so much for bringing that reflection here. I think it's it'd be really great for everyone to have a think about that as well. Any other questions at all? Brilliant. Well, Keely, you are coming back to us after the next presentation. But thank you so much for part one. And next up, we have Liz Bright, who is a consultant urologist and specialist relief urology at the Royal Cornwall Hospitals, who is also going to be doing a case study on MDT preparation. Thank you, Liz.
Thank you, Dua. So I'll try and share my content. Is that working?
Not yet.
Oh dear.
The joys of sharing screens on Teams.
Yeah,
Sorry,
my Teams is a bit dodgy, so I should have sent these to you earlier today.
Sorry at all. If you can't get them up, then you can share them. We can get them up. So see you again.
Bear with me a moment. I will email them to you. Chat amongst yourselves.
Sorry at all. Known for my Teams issues. It's always fun.
So whilst I'm just trying to get NHS Mail to work as well, I will just briefly say why I've been invited to do this talk. So some of you may have heard some of this before, and some of you may have heard part of this talk before. So I started as the cancer lead for urology in Cornwall about 5 years ago now, and it's actually a post that I've handed on to somebody else. But during that time, I radically changed in conjunction with the MDT coordinator. We changed the way we did things because our MDT was very outdated. What I inherited was an MDT that was essentially trying to be a lunchtime meeting that got bigger and bigger over time. And we were trying to squeeze in discussing about 60 patients into a 45-minute, 30-minute slot when people were then running off to theatre lists and clinics. And this clearly wasn't the right way to do things. So we had to make quite radical changes to try and make sure that we were doing a proper MDT, essentially. So just give me 2 seconds. That is being emailed to you guys now, sorry.
Great. Did you send it to me or other people on the team so we can?
England CMIP?
Yes, yeah, perfect. Thank you so much.
Is that the right one?
Yes, that was perfect. Thank you. We will get that sorted. Robin, would you be able to share or do you want me to try?
I am happy to share. I'm just waiting for them to land in the inbox.
Wonderful. Thank you so much.
But as soon as they land, I will share them for you, Liz.
Great.
Thank you.
Thank you. It's okay. We're actually really on time, so it's all good.
So I'll start talking through them because I can see them obviously when you've got them, share them. So this session was about preparing for an MDT well. So in order to prepare for our MDT, to make our MDT actually functional and usable, we had to identify what the problems are. So firstly, we identified that we were trying to squeeze a very long MDT with lethargic clinicians trying to do it into a short period of time. We also realised that historically, the way we worked, it was that it expected that every consultant neurologist within the department would attend the MDT. Now, as time went on, we all became sort of super subspecialised, and it was noted that actually some of those clinicians weren't actually really doing very much cancer work at all. And some of those clinicians didn't even want to be doing any cancer work. So it seemed a bit silly for them to be sat there not discussing any patients because they didn't bring any patients to the MDT as well. And obviously during that time, whilst they sat in the MDT, there was no other clinical activity going on in the urology department in that time. So we essentially identified the correct clinicians that should be in there. We also worked out that the MDT list was very long and there was lots of patients that weren't actually of any benefit being on the MDT because there were patients listed for discussion without incomplete data. There was patients listed which nobody knew. None of the urologists had ever met. Nobody knew what the patient was like, what they knew about their disease. And there were also patients listed for discussion in which the discussion wouldn't actually change the current management plan they were on. What we also had was a lot of laborious and repetitive admin processes because we didn't have a fully functional electronic system for our MDT. What we had was an electronic system for e-notes, for records, for the patients, but we weren't actually utilising that for our MDT. So how are we doing with those slides? Sorry.
Oh, I can see them. Can you not
Oh,
see
thank
them?
you. Excellent.
Okay.
So if you flip to the next slide. So what did we do? So we actually made 13 changes in the end. A lot of them were admin processes. A lot of them, as I said, was personnel, people who were in the department, who were in the MDT. We actually also distributed the workload because we had a lot of people doing a lot of work after the MDT and some people doing nothing. We implemented some effective follow-up clinics after the MDT to also get rid of some of the admin burden. And we agreed and implemented some standards of care to try and identify patients that didn't need to be discussed at the MDT. They could be on a standard of care pathway. All of this was designed by myself at the time, the cancer lead, in coordination with my MDT coordinator, who I have to say is the most vital person in your MDT. So work closely with them because they will tell you the processes, how things can be changed for the better to help not just them, but the whole cancer services pathway group and also your own department. And when we made these changes, we essentially agreed them at a urology away day. So we had an agreement that everybody who's involved with the MDT would be given the morning off, and we went off site so you weren't distracted by what was going on at the hospital. And we discussed through all the changes that we proposed, and we only implemented the ones that every single person agreed with. So, for example, some of the standards of care, some people were a bit uncautious, a bit overly cautious about, a bit worried about changing. So we didn't implement them because we had to say that all the changes needed to be something that everybody who sat in the MDT was comfortable with. If you move to the next slide, please. So changes in personnel, as I said, I actually kicked out some of the consultants. We kept 5 consultants in and 4 consultants left the MDT. That freed up those consultants to do theatre lists, to do clinics, to do extra activity that currently wasn't being provided in the department. So our managers loved it. And we sectioned the MDT into different sections to allow better use of our pathologists and our radiologists' time. So we discussed those that only need pathology discussion first, those that need pathology and radiology, those that need radiology only last. So our pathologists can leave early, our radiologists can start late. And a lot of people do this, and I've seen this all over the country in departments where I'd worked previously, but for some reason they didn't do it in Cornwall. It never occurred to them. Everyone just turned up at the same time and sat there. Next slide, please. What were the changes in our admin? Well, probably the most important one was we said that only members of the MDT panel could actually add patients to the MDT. Prior to this, every man and his dog who worked in the hospital, in the trust, could add a patient to our MDT. And that led to lots of patients being on the MDT that none of us knew anything about. We didn't know who the patient was, how they'd come to be there. We didn't have all the full information. And you actually had to spend more time discussing those patients to realise we can't discuss this patient before you can move on to the next one. So we put that in place, and our MDT coordinator acted as the gatekeeper for that. And she did that in conjunction with the cancer lead and the CNSs as a backup. So if she wasn't sure whether the patient should or shouldn't be discussed, she always had somebody she could go and run that past. But if that patient obviously wasn't ready for discussion, then that referral to the MDT would be rejected, and they would be signposted to another appropriate pathway for that patient to go to, which invariably is usually they need an urgent outpatient appointment or a 2-week wait outpatient appointment. We created an electronic add to MDT form because prior to this, I had to email about 3 people to make sure a patient got onto the MDT. And that was a huge waste of time, lots of repetition in admin. And specifically for the help for the MDT coordinator, we created an organ-specific MDT outcomes pro forma. So because in neurology MDT, we might be discussing 5 different organ-specific cancers, or 6 in neurology, we had to create one for each different cancer site, and it allowed her more time to listen and less time typing. And then that pro forma was converted into an electronic form that could be uploaded to the patient's electronic records. Because prior to that, we had no way of knowing what had been discussed at the MDT via looking at the patient's records. The only way you knew was the fact that all of us had to scuttle away at the MDT and dictate a letter for admin purposes purely, which again, to me, felt like a complete waste of admin time. We implemented post-MDT clinics. So our MDT now is a whole Thursday afternoon. And what we've done is we've implemented consultant-led post-MDT clinics and CNS-led post-MDT clinics that occur on a Tuesday morning. They couldn't be a Friday because you need to give patients enough time to get to the hospital. And we wanted to avoid Mondays because eight times a year that will hit a bank holiday, and then you'll be having to create new MDT clinics, which is a nightmare. So all of these changes were discussed, as I say, at our Urology Away Day, and then they were rediscussed either 6 monthly or yearly at another away day to ensure that everybody was still happy with the processes that we were undertaking. And if needed, we then instigated an iterative process of changing and implementing new changes. Next slide, please. So this is just an example of our electronic add to MDT form. So we use Maxims as a patient electronic portal for ordering tests, looking at test results, looking at letters, everything. And you can see here that it's quite easy for me to fill in. I just say it's me filling it in. I'm going to present the patient. I want it on the pathology only section. The patient's performance status is 1, which is always really important to know when you're making a decision about the patient, but also cancer services need to actually track and record that information. And then on the left-hand side, you've got the clinical details. So I would literally write in there the most important salient things that need to be discussed. And then lower down on the form, I put my proposed question. Does the patient need this or this? This is what I think is going to happen to them. If you can flick to the next slide, please, I'll show how that then converts to what we see at the time of MDT. So again, all the information that I've put in goes into that middle column. And then the far right column, as you're looking at it, is actually the column that the MDT coordinator fills out whilst she's doing the MDT. The first bit, MDT discussion, is for her to write free text, but all the other ones after that are essentially drop downs that she can select, because what we noticed she was doing was she was typing all the time, having to type my name and then maybe my name again. I was going to do this, type. She's typing the same things over and over again. And that was just an absolute waste of her time. And actually, she's so speedy now that she's sometimes even pre-populated this whilst we're having a discussion, because she's second guessing what we're going to say. And it doesn't take her very long. And we look up and say, yep, that's fine, perfect, move to the next patient. So if you flick to the next slide, I'll show you how that view shows for her. So for this example, because this is a bladder outcome, we've selected here the most common outcomes for patients with bladder cancer. And so she would select one of those items, so low risk follow-up, intermediate risk follow-up, etc., etc. And it means she doesn't have to type that every single time, but she can add some additional information if there's some nuances to that patient. And by flicking to the next slide, I'll show you that the lowest bit, which is patient informed by, she's got every single person's name there, plus also CNS means the CNS is going to give them a phone call, or they're going specifically onto the consultant MDT clinic or the CNS MDT clinic, which will then link to our secretaries to be able to book those patients directly. But it just means it's less typing time for her, and actually it speeds up between patients in our MDT. So if you flick to the next slide, I think that's my conclusions. So what has been the result of this? Well, firstly, we've halved the number of patients on our MDT. We've freed up our non-cancer urologists essentially to do more other activity. We're using better use of our radiologists and pathologists' time, and they both absolutely love the MDT now. All the radiologists, all the pathologists that are involved said they told me they used to dread the urology MDT, and now they actually find it quite enjoyable. We've got quicker and more comprehensive MDT documentation, which is so important. It's so frustrating when you get a patient back to the clinic and the documentation from the MDT isn't very good and you can't really work out what was the thought process in the MDT and you're having to try and translate that to the patient. It's an absolute nightmare. Most importantly for me and my colleagues, we've got less admin post MDT and less repetition of admin because we're all trying to do things shorter and smarter nowadays. We've got improved patient pathways because actually our patients are getting through very quickly. By implementing those clinics, our patients are getting through really quickly now. We used to have patients waiting weeks and weeks after the MDT to be seen, which was just soul destroying and heartbreaking to see. And actually, because we've got more engaged clinicians and more time to discuss those patients, we've got a better quality of discussion per patient in the MDT. I think that's my final slide. Thank you very much.
Brilliant. Thank you so much, Liz. I think it's like so great to see those, you've implemented those 13 changes and how engaged everyone's been with it. And I think it's, yeah, really, really important to see and like hopefully useful for other people to see what kind of changes you've put in as well. Does anyone have any questions for Liz? Robin?
Hi, Liz. Thank you so much for sharing that. I just wondered, you said that only members of the MDT can refer patients to the MDT. So what is the process if somebody else wants to refer a patient to MDT, for example, from another hospital department, from A&E, somewhere like that? What actually happens?
So the MDT coordinator, as I say, acts as the gatekeeper. She will then basically review why that patient's being added, what the question is that's being asked. And she's such a vital member of our team now. She's actually also at the point where she'll know, have they had the appropriate scan to answer that question? Have they had the appropriate clinician see them to answer that question? And if she's unsure, she'll then run it through usually first through the CNS team, who may contact the referrer and have a conversation with them and liaise first. Or it might be something as simple as, actually, you've got the wrong end of the stick. This person doesn't need to be on the urology MDT, because we've looked back and actually they went through our MDT 6 months ago. The patient is aware of this and it's something we don't need to worry about. So it's very much the MDT coordinator working in conjunction with our CNS team to gatekeep that. If our CNS team think actually this person needs to come through the 2-week wait process, then our CNS is actually triage all our 2-week wait referrals anyway, and patients are pre-investigated before they see us. So it also speeds up that process, because what they would then say, for example, it might be a small renal mass that somebody's picked up on a scan in the gastro team. Our CNS team will actually go back to that clinician and say, well, thanks ever so much. Actually, we haven't got the right sort of scan. As always in the NHS, there's always a different sort of scan. We haven't got the right sort of scan, but we'll arrange that, and then we'll get the patient into clinic, and then we'll get the patient to MDT. So we don't just say, no, thanks, go away, sort it out for yourself. We sort it out, but we don't sort it out through the MDT. I think historically, the MDT used to be the dumping ground for, don't know what to do with this bit of admin I've got. I'll put it on the MDT and somebody else will sort it out for me. And that wastes a huge amount of time. It's about using your MDT time effectively. And actually, you still got to use that time, but you just use it in a different way so that the patient gets the right pathway.
Great, thank you.
I feel like other people might be able to also agree with that dumping ground idea. It's interesting.
Yeah, it is. And as well, you'd be surprised. A lot of people said to me, how did you manage to remove consultants from the MDT? You'd be surprised when you actually ask consultants whether they want to be there. Some of them actually say, no, I'm not interested in treating cancer patients. I had one consultant who said, I hate treating cancer patients. I hate talking about cancer. It really upsets me. And I don't want to be in the MDT. And actually, they are now purely a benign consultant. And, you know, you can have open conversations with people and make sure people are working in the right places as well within the department they want to be in.
That's really helpful and interesting. Like, yeah, great to see you to have those conversations and be able to be open as well. That like that consultant saying, like, actually, I don't really want to be here. It's fair enough. If they're not needed, then why be there? But thank you. Any other questions? If anything comes to mind later, then you can always pop questions into the chat as well. Yeah, but thank you so much, Liz. We really appreciate you coming back.
Thank you. Goodbye.
Thank you. See you later. And next up on the agenda, we've got Keely coming back to talk about post-MDT patient communication.
Hi everyone, thank you for having me back again. I'm just going to share my slides again, so just give me the heads up if you can see them.
Just waiting for them to full screen, but yes, we got it.
Yeah,
thank you.
So yeah, now we're talking about communication of patient outcomes. So again, going back to our Greater Manchester standards, when we started our reform projects, one of the standards was to improve the turnaround time to speak to our patients. So it's something that we felt we had got certain parts of our pathway really slick, but actually speaking to our patients was really quite difficult. And as a CNS team, I've said we really try and focus on that smooth pathway and making sure patients are informed when they're being discussed on the MDT. And quite often we'd find our patients were calling us saying, have I been discussed? What did they say? I need to know. Really anxious conversations. And essentially patients just want to know their information as soon as possible. So it was about increasing that turnaround time. So we looked at how we could do that. And as well, going back to when we had COVID, we offered patients telephone calls to get their diagnosis. Some patients were only allowed to come to hospital on their own and they had relatives on the telephone, and actually they preferred just to be at home. So we now give our patients the choice as to how would they like to receive their information, where's the most comfortable place for them. As well as communicating patients' outcome to the patients, we looked at how we communicate that to clinicians. So we looked at our turnaround time for the letters that were going out to our GPs, and as well making sure we did online reporting to patients who were inpatients. So people who were referring into the MDT from the wards had an instant outcome to communicate to their patient. So key to communicating our outcomes was making sure our patient was informed as to what was to happen to them. So for us, our patients are constantly told they're on a cancer pathway. So they're referred via their GP on a suspected cancer pathway. They receive an appointment with one of our straight to test nurses and they say they're requesting investigations on a cancer pathway. We then meet patients in endoscopy and say, we've found a suspected cancer and we're arranging staging investigations, so that by the time they come to have their MDT discussion, they're expecting their outcome will be that they have a cancer diagnosis. So to jump from you have a suspected cancer to a cancer, patients just often want to know yes or no, do I or don't I, and do I have treatment options? So we looked at how we could improve our appointment turnaround time. So we set up a nurse-led clinic. So we looked at possibilities for potentially having a post-MDT consultant clinic, and we couldn't job plan it. And actually we used to have one straight after the MDT, but the outcomes for patients sometimes weren't ready, patients weren't able to make it in time. So setting up a nurse-led clinic enabled us to have a telephone clinic the day after our MDT, and patients were getting their outcomes within 24 hours, and they were actually being given their outcome via CNS. So setting up that clinic, we could only do it because we had a really experienced team of clinical nurse specialists. All of our team had kind of training in breaking bad news, advanced communication skills, and psychology level 2 training. And we've all been doing the job quite a long time and been part of those discussions of breaking bad news. We also, again, going back to the pathway, setting up clear expectations for our patients, making sure they know when they're going to be contacted, and making sure we get their wishes as to how they want to be contacted. So actually, as part of our patient impact statement, one of the questions at the bottom is, how would you like your MDT outcome to be communicated with you? How do you receive information best? And then the patient would make a choice as to, I wish to have a face-to-face appointment because I get information better that way, or I just want to know as soon as possible. Please, can you ring me when you know? So we went about writing an SOP, and we identified appropriate patients in which the CNSs could contact. We arranged admin support, clinic codes, letter writing on the back of all of that. We then looked at job planning time for CNSs and where would that clinic take place, what resources would we need to do it. So initially we started it straight after the MDT, but you can imagine being sat in a long MDT and then phoning a load of patients on the back of it. It's quite a long day for the CNSs. So we decided to do it the next morning, where we were coming in with fresh heads. We had space where we could each go to our own clinic area to do that individually. And we agreed in the MDT which patients would be appropriate to be contacted in that clinic by the CNS team. And if they didn't wish to be contacted by CNS on the telephone, we ensure that they had a timely follow-up appointment face-to-face with a consultant. So initially we set out that we would just contact certain groups of patients, but we found out actually, if you're offering patients the choice, once you've given that choice, you can't take it back. So if you say to a patient, how would you like your MDT outcome to be communicated to you? And they say on the telephone, but actually they've then got metastatic disease, you have to be prepared to give that information on the telephone. And it's about preparing our patients that they may get that information on the telephone, and is that the right place for them? Also making sure they've got the right people around them when they're getting that information, if they want to have family there, that they're given a time where they're going to be contacted, so they can make all the right arrangements to be comfortable. So we now contact all of our patients from the MDT who wish to be contacted, whether that's a new diagnosis, patients who need additional investigations, all of our patients with post-op histology, and now metastatic disease and patients with disease recurrence. So since we introduced the clinic back in May 2023, year on year our numbers having increased, and we've contacted over 500 patients through this clinic now. And we found that we've actually seen an improvement in our FDS standard, our 28-day target. So there is a significant difference in the time in which it takes to have a CNS telephone call and then be seen by a consultant. So it's really important, because that's the biggest time where our patients are worrying the most, where they have a suspected cancer, but they don't know what's going on. They don't have a treatment plan. They don't know if there's disease spread or what their options are. So by contacting them a few days earlier, it does relieve a lot of anxiety. And even if it's bad news, patients would just rather know and know that they have a plan moving forward and support moving forward. So yeah, we found that we've actually met FDS for just over 50% of our patients. And for those where we've not met FDS, we've looked at themes in which we could potentially improve that and looking at patient pathways. But actually, without the CNS clinic where we contact patients the next day, we would have hardly met FDS for any of our patients. And that's obviously a really key target for us to be meeting. So the benefit of having the clinic, we find it's given our patients choice as to how they want to receive their information, and making sure they're in a comfortable environment with the people that they want to support them. It improves the time in which they get their MDT outcome, improvement in our FDS standard. Also, anecdotally, we feel our patients are more prepared when they come to their clinic consultation. So often when we sit down with our consultants and we tell patients, you have a cancer and we'd like to consider doing an operation, this is what it involves, patients are tied up in that you have a cancer, and they don't always listen to the information about the surgery, and they come back with lots of questions, not taking that information on board. Whereas if we prepared them to say, you do have a cancer, it is treatable, your treatment options are X, Y, and Z, and you're going to come and meet our consultant to discuss that in more detail. When they come to that consultation, they're much more prepared, they've got a set of questions, they're taking on board what the consultant's saying to them, instead of focusing on that diagnosis and that initial, oh gosh, that's just hit me. So we do feel that that's a really key improvement. It's also improved our capacity in our consultant clinic. So we're getting patients to see the right consultant. So if a patient's for radiotherapy, they're seeing a clinical oncologist. If they're for surgery, then they're seeing a consultant surgeon, and various things, so that we're not wasting capacity by them seeing lots of different people to get to that final treatment option. And we've obviously seen a referral in our turnaround time for referrals onto oncology and people like that. And for our CNS team, it's improved job satisfaction, because it's another element of things that we can do in our role to keep advancing. Obviously, doing this clinic does come with challenges. The biggest one, again, is time, creating the time to be able to do that. Initially, there was some anxieties from the CNS team to, are we the right people to be doing that? Do we feel it's appropriate? Do we want to contact all patients, or actually is there a subset of patients where we shouldn't be contacting them? And it was changing that culture as to, it's not about us, it's about the patients and what they want and how they're going to be comfortable. And as long as we prepare them that whatever information they're going to receive, it may be bad news, it could be disease spread, it could be limited treatment, as long as the patient is prepared for that, then it's their choice as to how they want to receive it. Another challenge that we see is space, finding clinic space. So nowadays for our telephone clinics, we struggle to find a clinic room to do it. So we now often, when we're doing this clinic, we work off site at a separate clinical area where we can do our telephone consultations, so we don't get interrupted, and we've got the appropriate time to spend time with our patients and do all of our accurate documentation after the clinic. So yeah, any questions about setting up that clinic, please feel free to ask away.
Oh, thank you so much, Keely. That is, yeah, I think that's a really interesting way of doing things. And like, I think the ability for patients to be able to prepare rather than just sort of have a panic on the day when you give them such big news is so, so important. And yeah, it's clearly having an impact, and completely understandable. There's always going to be issues when you do something. So things like the time restraints and like the change in working and like space and things like that. But hopefully more positive, like more pros than cons. But that was really interesting. Thank you so much. Liz, hand up.
Yeah, thanks, Keely. I just think that's really, really well shows how CNSs can be used to their full potential. So our CNSs, when we started getting them to be giving patients cancer diagnoses, they were a bit cautious. Now they sit in the MDT, and they are very vocal in our MDT, and they sit there saying, why are you seeing that patient? We can do that. And they are literally taking patients off of us, which is great because they know the patients so well. They've already probably spoken to them a couple of times already. And actually, the patients don't care who gives them the information. They just want it as quickly as possible.
That's very much the case that we've found, definitely.
Yeah.
And I think it is key to just empowering your nurses and, like you say, tapping into their full potential, because we do have a team of really experienced nurses, and it is about changing that job description and evolving. I think sometimes as a CNS workforce, we feel lost with the new force of ANPs and people like that. But actually, we do have years of looking after these cancer patients and sitting there with consultants and seeing how they receive bad news and supporting them through that process. That we do feel like we do it, and we do it well. We like to think anyway.
Absolutely. Do you get your registrars to sit with you in clinic? Because I think the registrars can learn a lot of how to talk to cancer patients from the CNSs. So just something we do as well.
Yeah, that's a good idea.
Yeah.
Thanks, Liv. It sounds like a really powerful culture shift. So it's really great to hear. I can't tell who in Violeta's room has asked the question, but go for it.
Yeah, hi, sorry, it's the team from the Owl Plan. We've asked a question on the chat, we just decided to say it out loud. We just wanted to ask how many patients, just the approximate amount of patients going through the MDTs and the number of CNSs supporting that.
Yeah, so usually we have about 20 patients on our MDT, and we then have 2 nurses who do the clinic, and we each usually contact between 5 and 7 patients, and we allocate a full morning of job planned activity to do that. And obviously, there are a group of patients who don't want to be contacted on the telephone, they feel like that's not the right thing for them, and then we do ensure that they have an appropriate follow-up face-to-face appointment. So usually it's about 5 to 10 patients per nurse each week that we contact.
Thank you.
Thank you. Any other questions? Brilliant. Well, thank you so much again, Keely, for coming along to present. And yeah, if anyone has any questions, please do feel free to pop them in the chat box. Thanks again. So, final thing on our agenda is we're doing a group exercise. We're not going out into breakout rooms, don't worry, but we're going to do our favorite activity now, which are chat bombs. So, the first question is, actually, can we pop it on screen and then we can.
Sorry, let me just get the slides
No,
back
no,
up.
don't worry. Thank you.
They are the wrong slides, sorry.
That's okay. It's one of those days.
It is
All
one of
good.
those days on Teams.
Well, I will tell you so you can have time to think about it whilst we're getting them up. So, the first question is, I could support preparation of the MDT by, and so you've got 3 minutes. So in the chat, just type out your answer, but don't press send just yet. And I'll give you 3 minutes to come up with an answer. Felt like an unusually long 3 minutes. Could everyone press send on their answers, please? Okay, lots of answers. Let's read them out. So the question was, I could support preparation of the MDT by, and we have pre-MDT review of cases, supporting whether empowering MDT coordinators, giving time, creating pro formas, pre and post MDT sessions, getting patients involved in the MDT prep, how they want to be contacted. Introducing that each responsible clinician should enter the summary of each case for discussion. Having up-to-date information of the patient's views of their treatment plan, if that's the patient's known to the team, and working with the MDT coordinator to ensure the entire CNS team can answer queries. Preparing, yes, that's a very useful. Definitely doing some preparation. Amazing. Thank you so much. So
I think
we have
just to add to it, I think the range of answers that are in the chat really kind of highlights that actually preparation of the MDT is everyone's responsibility in the
for sure.
MDT. I mean, there's so many answers there that kind of I think people are doing from the perspective of their role. And I think it just highlights that actually it's not just on the MDT lead, it's not just on the MDT coordinator, that actually everyone has a really important part to play. And I think people have really reflected that in their comments.
For sure. And it definitely seems like everyone has an idea of how they would want to do that prep. Because I think sometimes it's just trying to get everyone more engaged and having those conversations. So yeah, really, really great to see. So we have another question, and same process again. So what support do you need to be able to do that? So if it's, my MDT coordinator could help me to do XYZ, or my MDT lead could help me by doing XYZ. So again, if you could type your answer in the chat box, but don't press send just yet, and I'll give you another 3 minutes of what seems like a very long 3 minutes, but another 3 minutes. And could everyone press send? Okay, lots of answers coming through. Does anyone want to come off mute and talk to us about either their answer for this one or for the first one? Anyone keen to share more detail? No, that's okay. I can read it out. So what do we have? first one, coordinator being able to track patients effectively in a timely manner. We've got regular and fruitful discussions, so whether it's face-to-face, email during clinics, yeah, so keeping engaged with one another doesn't have to just be during the MDTs, but outside the MDTs as well, with the CNSs who know the patients and the MDT list. Creating a survey for patients at the point of coming to the clinic or during diagnostics. Violet, who would support you doing that?
Sorry, did you ask our team?
Yeah, I was just curious, as in who is it that you think who would it be creating the survey for patients?
Well, I think we've been thinking about involving the patients, in creating this survey along with clinicians. So that would definitely help. And at the point of referring the patient on a urgent suspected cancer pathway, there has to be a clear communication so the patients know exactly where they've been referred to. And then when we decide whether they are for the clinic or the following diagnostics, we could provide with a survey asking for their opinion on what do they expect and how they would like to be contacted. So then it supports further MDT discussion if they are calling for the MDT.
I mean, it's quite impressive listening to Keely being able to go up to endoscopy, but unfortunately with our service, we just cannot do that. So we're trying to work around it and see how we can incorporate this in a different way.
Yeah, I think that's the thing with these sessions is like we don't expect you to copy paste everything that you've learned, but like being able to take parts and implement them and see how they work with your like current systems, I think is really, really useful. So that's great to hear. More things we have. So protected time outside of clinical activity to work with the MDT coordinators and MDT to agree changes / improvements before implementation. That's really useful. Tracking patients and FDS targets and changing job plans for almost the whole of the MDM team. So better attendance in the MDM and engagement of the whole team. Robin, did you want to comment?
Thanks, Stuart. I just wanted to pick up on one of the comments. So Elizabeth has stated that they need support from their MDT coordinator. The MDT coordinator obviously tracking patients effectively and in a timely manner, which is absolutely right. And that's really, really key. But I'm just wondering if the coordinator needs more support to do that. And I think a lot of these questions are actually quite interconnected. So if you need support from someone else to do something, then perhaps that other person also needs to support to do something. So, if you feel like the coordinator needs to do that more effectively to support your job role, absolutely. But I'd probably go back and question actually what support could the MDT coordinator need to be able to do that? What kind of conditions do they need to be able to do that? Just a thought for kind of digging in a little bit further.
Great, thank you, Robin. Does anyone else want to come in and share? I think again, it's really shown like how important like every single person is in the MDT and like how all those roles are really important. And we do need to, I say you need to keep engaging with each other. And this just shows that you have an idea of what it is you want how to make those changes. But I know it's easier said than done. But yes, thank you so much, everyone, for taking part in those. We just now that we've just taken that idea from gosh, we're just going to keep using it. It's just a fun little activity and we'll just keep using it. But yeah, thank you again to Keely and to Liz for your presentations. I really appreciate you guys coming along. So our next session, which will also be our last session this year before our closing session in February, is going to be on the 18th of December from 10 to 11:30 a.m. and we'll be focusing on communication and leadership. If you don't happen to have the invite in your diary, then please drop us an email and we will send it over to you. Again, thank you so much, everyone. Thank you to everyone here for engaging in this program and for engaging today. We really do appreciate it.